Hi everyone, my name is Richard Wiley and I'm the CEO of Glaucoma Australia. Welcome to the next episode of our exciting live Q&A series. And firstly, let me introduce you to our very, very special guest today, Dr Hamish Dunn. Dr Dunn is an ophthalmologist working in regional New South Wales. He's actually based in Port Macquarie right now and specialises in glaucoma. He holds a PhD from Sydney University in optimising eye examination by non-eye health professionals. Dr Dunn works with RANSCO on glaucoma education requirements for ophthalmology trainees and collaborative care with optometry for patients with glaucoma. So we're very fortunate to have Dr Dunn here with us today. It's also a particularly special week for Glaucoma Australia, as it is World Glaucoma Week. So we have a whole host of activities this week, including a number of these live Q&A sessions. So without any further ado, I think I'll hand over to Dr Dunn.
Thanks very much, Richard, and thanks very much to Glaucoma Australia for the opportunity to talk today and discuss some questions. So the talk we were thinking of doing is something about early surgical intervention for glaucoma and the updates there. But as I was preparing this and thinking about the topic, I think it becomes more important to think about optimally timed surgical intervention for glaucoma, which is really about a balance of thinking about the risks and benefits of going ahead and starting drops, laser, medicine, surgery, and fitting those options with what the patient really wants to set as their goals and the things they'd like to avoid. So in summary, what I'll go over is about the first 10 minutes of why we would intervene in glaucoma, a bit of a look at the treatment spectrum. So what's available, what's some of the newer evidence that's come out and what helps us determine when we should go ahead and do a surgical intervention. And then we could finalise towards having a discussion about balancing those risks and benefits and translating it to individual patients who'll come and see their doctors. So why would we intervene? Well, glaucoma is a chronic, progressive and irreversible optic nerve disease. So it's coming on it for most people slowly. It does keep going. And if we get damage, then we can't gain the loss of vision back. But not everyone is going to lose vision. We want to intervene in the right people at the right time because we know that glaucoma-related blindness affects one or both eyes in somewhere between 3 and 12% of patients with glaucoma. And in some patients, early surgery, especially when the pressure is very high to begin with, likely prevents more field loss than medicine or laser. Now, some of that kind of groundbreaking work that was done back now in the last millennium was also done before the advent of new medications. And so we need to interpret that in the light of changing access to a whole range of different strategies to manage glaucoma. And in our way to approach glaucoma now, we now have a whole suite of surgeries that can come with a lower risk profile and come with advantages that we hadn't thought were possible before. So the minimally invasive glaucoma surgeries. There's been a lot of big long-term trials that give us better evidence for when and how to intervene and what the risks are, particularly for the traditional glaucoma surgeries like trabeculectomy and tube shunt surgery. And there was a fantastic study out of the UK called the UK Glaucoma Treatment Study, which looked at visual field outcomes, which is really the thing we want to know for patients, that we're preserving visually important function. And an important finding on that, alongside the fact that medication did preserve people's visual function much better than not being on it, was the fact that 2/3 of patients who didn't get the medication, they got the placebo in that trial, still had no detectable change in their visual field over 24 months. So that tells us there is this important subgroup who won't get worse with their glaucoma. And so not everyone does need early surgery. In fact, there's a group of people where we can safely, if we determine they've got low risk, we can monitor for a while and not necessarily even start medication. And so it's about working out for the individual patient that we're meeting to have that discussion about what's the risk and then how much risk are people willing to tolerate and what should we do about going forward with it. So here's just one example of one of my patients I met quite late, unfortunately, in his glaucoma journey. You can see here the two fields on the top left and top right there were a year apart, and he's had some slow progression in his glaucoma at that stage, and then unfortunately had some other health issues and couldn't get back for glaucoma care until several years later, when if you look at the graph down the bottom, he'd dropped off a fair bit in his vision, and so we were left with this field when we caught up at that stage. Now, this was a few years back, and we went to the traditional core of things, and we went straight to a trabeculectomy because it's quite advanced disease. And a trabeculectomy bypasses the normal drainage, lets the fluid out a different way. It's a surgery that's been around since the 60s, and it's still the gold standard of advanced glaucoma because it works very well. And so for him, you can see that for the years after we've done that, we have maintained that visual field that he's got. But the question, I suppose, with a talk like this is, if we could intervene at a different time, when's the optimal time that we would intervene, and when would we accept the surgical risks and benefits as we go forward? So some of the evidence that's come out around this was there's a big study called the TRAB versus tube study, or sorry, the tube versus TRAB study, which was comparing our two big guns in this, the trabeculectomy and the tube shunt surgery. So in the top picture there, you've got a trabeculectomy filtering out, bypassing the normal filtration pathway and making a little bleb up under the eyelid. And below that, you've got a little silicone drainage tube that feeds to a little plate behind the eye muscles. Now, these surgeries have both been around since the 60s and 70s, respectively, and they work very well. But on the right in the table, there's a lot of information there, but the take-home message is kind of roughly 1 in 5 people can run into a complication with these that needs further surgery over 5 years. Now, that can be fixed. This is not a death knell for the vision by any means. These are things that can be adjusted, but it means that probably 1 in 5 people is going to need further surgery to keep things going if they've had one of those 2 major operations. And so that kind of informed what we would normally do with a treatment pathway, which was you would start on drops, and then you would get onto the maximum number of drops, and then we would consider a laser. And then after a laser, if that still wasn't working, we'd go on and do a trabeculectomy. And then if a trabeculectomy still wasn't getting there, we'd think about a tube shunt surgery. But that pathway's been modified quite a lot and adjusted for individual patients because we've got access to a whole new suite of options for patients with glaucoma, and we can intervene for appropriate patients at an earlier stage and avoid some of the bigger surgeries and avoid some of the complication risks that go with that. So with medications, they work exceptionally well. Anyone who's on medications, we've got really good evidence that that's preventing you from losing your vision. So it's doing a fantastic job. But for a lot of people, it is quite difficult, especially by the time you're on 2 and 3 medications, to keep up with that schedule of which drop am I doing in the morning? How long do I have to leave between the afternoon drops? People can get side effects either from the drops or from the preservatives that go into the drops to keep them okay for the month that you're using them. And some people will still progress despite having that. And then on the side of surgery, like I've just talked about, there can be complications and side effects. These surgeries, when you need them, are sight-saving surgeries, and we've got really good evidence that that will do the job we need, but they come with problems like leaks develop or infection, and those things are rare, but we need to balance when the risk of not operating is higher than the risk of operating for those things. Well, the first big change for this that I think is a major pivotal change was with SLT, or selective laser trabeculoplasty. It's been around for a long time, but there was this fantastic study out of the UK called the LIGHT study, and they had almost 700 patients who were randomized. They, essentially toss a coin. Half of the patients get the laser, half the patients get the drops. What they found at the end of 6 years of that was that quality of life was pretty similar between the two groups, but the people who had the laser had much less glaucoma symptoms. They had a much better pressure at almost every time point. So 70% of the patients were at their target pressure and didn't need additional drops or surgery. Much fewer of them progressed on to get worsening glaucoma. So fewer people lost significant vision. That was 27% of the people who had drops lost some vision, but only 20% of people who had laser lost some. There were less people who needed to go and have the bigger surgeries. So this reduces our chance, if we have a laser early, we're reducing the risk 6 years down the track that you'll need the trabeculectomy. So if you had drops, then 32 eyes, this is not 32 individual patients, in the trials they count number of eyes. So it's 32 eyes needed to go on and have a trabeculectomy versus only 13 eyes if you'd had the laser at the start of that 6-year period. And actually cataract surgery was almost half the rate as well, so 95 eyes versus 57. So that tells us that SLT is actually superior to drops from the outset. And if we do that early, this has changed my practice pattern, and I recommend laser much earlier because the risks are very low, but the benefit is there in the long run. The other laser that's come out more recently is a variant of a very old laser called cyclodiode. So cyclodiode acts here at the ciliary body, which is the little part of the eye that produces the fluid. It's the pump putting the fluid into the eye before it drains back out. And cyclodiode traditionally would knock off or kill off a small part of that pump so that we can adjust the pressure down. But that comes with its own risks of you're permanently knocking something off. Micropulse, instead of doing a continuous laser, does little pulses of that laser. And as a result, you kind of stun the ciliary body so that not as much fluid is being produced, but also it seems to access other ways of draining the fluid. And as a result, you get a reduction in the intraocular pressure. It has a much lower risk profile than traditional lasers, and it can be put at any stage in the glaucoma pathway. So you can use it very early, in the middle when you're trying to avoid some other glaucoma drainage surgery, or even someone who has, a tube shunt or something like that. You can top it up with this laser as well. And as a result of this, we kind of shift that pathway. So instead of going drops then laser, it's kind of, we talk to the patient and decide, do they want to go for laser straight away, or are we going to bring it in earlier to the party and shift between those? But that still leaves us with a jump between people who are, drops and or laser, and this big jump to what we would feel like a bigger surgeries with a few risks. And there's a lot of people who are maybe not quite getting there on their drops. Maybe they've had a laser and it hasn't worked effectively enough, or maybe they're just getting there, but the drops are giving them side effects, or they're about to have cataract surgery. So the next big jump in glaucoma surgery earlier on is this micro-invasive glaucoma surgery, or MIGS, sometimes called minimally invasive glaucoma surgery. And these things are alternatives to traditional incisional glaucoma surgery. So those surgeries they came up with in the 60s and 70s, which are variants again from what we've been doing since the late 1800s. These surgeries try to optimize the natural drainage pathway. So you've got a pathway that takes that fluid from the ciliary body, comes up into the front angle of the eye, and then from there it can get back into the bloodstream. And we use things like stents, like you hear in heart attacks all the time, that people have stents. So it's something that people understand generally now, but opening up that drainage pathway a bit better, or there are other ways around the drainage pathway, but they're generally alternatives to those traditional drainage surgeries. They're minimally traumatic. Generally, they're ab interna. That means it goes from inside the eye. So you're only having to make a small micro incision or a keyhole incision to put it in. Often it's done at the same time as cataract surgery because you don't add much in the way of risk when you're doing these surgeries. In fact, there's a big meta-analysis, which means they pull together all the different studies that are published, and they found that the additional risk of doing one of these drainage surgeries is very small. The only major risk was a slight chance of a spike in pressure for a few days, but no significant visual loss, and sometimes a bleed that can cause transient blur. There are other risks that your surgeon would talk to you about, but otherwise it's not a big risk change if you're having cataract surgery anyway. And the goals are a bit different. So this is more for mild to moderate glaucoma. So traditionally our trabeculectomy, our tube shunt surgery, we've got patients who are at risk of becoming blind or having severe visual dysfunction. In this case, because you've got a high safety profile, your target may actually be to reduce the number of drops. If we can get someone from 2 drops down to 1, that can be much more comfortable on their eye surface. Or it can just be much easier to adhere to a medication regimen. If you've got a busy life or you're working shifts and things, it's really hard to get a drop in at all the appropriate times. So again, they've got a high safety profile, lower complication, but we're targeting a different spectrum of disease here, really. It's that mild to moderate. We're just trying to make it easier to keep under control and make glaucoma, something that sits in the background instead of something that you have to have in the forefront of your mind all the time. So there are 3 broad targets for this. This is a bit of an older slide that Ike Ahmed, who's one of the gurus of MIGS, put together. And I just more use it just because it's interesting how far these things have shifted in even a short space of time. So in the yellow arrow, you've got where most of these targets seem to go through something called Schlemm's canal, which is that pathway where the fluid goes out into the rest of the eye. Out into the blood flow. And so that's where your eye stent that you will hear of, the Hydrus goes. It's where some of these newer eye track devices go. There's then devices in the blue arrow that do what a trabeculectomy would do. In fact, they're often called a trabeculectomy in a way, but it's a minimally invasive one. And so that's where you get the Zen or the PreserFlow, which used to be called InFocus. And then the other devices are not available at the moment, but were available, the CyPass. And that was one where initially CyPass was very successful, but then we had problems with the clear cornea at the front. So no one lost vision as a result of that in the big CyPass studies, and it did reduce intraocular pressure, but it was a risk. And in a way, that's probably been good for the MIG space because it put the bar much higher for making sure things are safe for patients when they go forward. But it's a consideration with the devices that are out and making sure they've got enough, what's the evidence for these in the long term. I'll briefly go on to these so we have time for questions, but the devices in that first space are the iStent Inject, which is the smallest implant you can have in the human body. It's a titanium device, and it's very good at lowering the pressure and medication use. There's lots of good prospective studies now looking at that reduction. The Hydrus microstent came out with a really impressive study with 6-year results now. 5-year results. And it was the first MIGS device to actually show that you get a preservation of the visual field. So previously we knew that the pressure was lower if you put one of these devices in, but this was the first one to show that actually you preserve visual function as a result of putting this in when it's done with cataract surgery as compared to cataract surgery alone. So that's exciting in this space because it does shift that balance where you think, okay, well, if I'm not increasing the risk of surgery very much at the time of cataract surgery, but we know that we're actually preserving visual function, then that makes it worthwhile doing something early. And then there's iTrack canaloplasty, which kind of works the same way, but it's stretching open that pathway. We talked about those subconjunctival MIGs. They're kind of an injection form or a kind of simplifying away of the glaucoma surgery. One of those big complications that we talked about with the traditional surgeries was the pressure going too low. We're trying to put a filter in, but we don't really have a tap. It'd be lovely to have a tap that we can dial. And I'm sure in 50 years we'll have something that can do that, or we'll have genetic variants where we don't need to, adjustments that way that we don't need to worry with it. But these things are quite good because they have a very narrow tube. It means it's easier to put something in that the pressure won't go too low for it. And so people recover much quicker from this operation. In fact, if you look at, here's one of my patients who a week after surgery and then 3 months after, the eye's back to looking nice and healthy. They can get back to full activity earlier. And one of the important things in the PreserFlow studies, for example, in some of the big ones, is the rate of other interventions for people was much lower. So you just have one thing and then less post-operative interventions, like what we call augmentations or needlings to get them right. That's a busy slide to just say these things all work quite well. Everything to the left of the middle line there means they're working, is the upshot. The upshot of all this is basically that traditional pathway where we're kind of going drops, laser, wait till everything hits the wall and then do a trabeculectomy or a tube. It's very busy, but there's a whole host of options to think about intervening earlier, as long as you weigh up those risks and benefits and have a discussion with your glaucoma surgeon about, what are your goals, what risks or what things are you worried about, and then is it worthwhile doing something sooner or hold off, and the chance of you losing vision isn't significant. That's an important discussion I like to have with my patients, that sometimes people are very worried about, I could go blind, and they're often quite, the vast majority of people with glaucoma will never go blind. So it's useful to have that discussion to just know, look, how worried is my surgeon about this? And that can help frame things for you. So thanks very much. That gives you a bit of an insight from my point of view, but I think there were some questions we were going to discuss with you.
Fantastic. Thank you very much, Dr. Dunn. That was really, really interesting. So we've got a series of questions. And the first one, I think, is probably the first question I would ask myself if I was in this situation. And that is, if I do elect to get surgery early in my glaucoma diagnosis, will that leave me with less choices for glaucoma treatment in the future?
Almost universally, no. So for some things, yes. I mean, the only if you jump straight to bigger surgeries like a trabeculectomy or a tube, or the equivalent things, it does make some subsequent surgeries a bit harder. But normally, if we're making that decision to jump straight to that, it's because the disease is more advanced, there's significant risk factors for it getting worse, and we kind of need to jump on it now. For a lot of these minimally invasive glaucoma surgeries, no. For any of the lasers, you can definitely, from any laser, you can repeat any other laser and any of the surgeries. From any of the angle-based devices, you can go on to have any of the other glaucoma drainage surgeries, and you can have a laser. And there's plenty of good studies now. I say good studies. There's moderate quality studies for a lot of combinations following that. The evidence for which one should be combined with what is emerging, but having any of those doesn't stop the next one. It would be important to say, if your surgeon's worried and thinks, oh, this is very advanced disease, and I think we should jump straight to the trabeculectomy, for example, because it's tried and true, there's good evidence for that as well. There was some advanced glaucoma intervention studies where they looked at people who came in with advanced glaucoma and should we put them on medication versus early surgery. And the early surgery group did a bit better. And actually, when that out to 5 years, it leveled off a bit, but actually the more recent data out to 9 and 10 years shows that the trabeculectomy group still did better in that case.
Great, thank you. All right. And how many times can surgery be done on one eye? And when would a surgeon decide it's too much?
Good question and tough question. There's probably not a known limit. So there are a few things. If you're going into the subconjunctival space, so those last ones we talked about where we're draining away from the normal pathway, the more surgeries you go in there, the more scar tissue you develop. And so subsequent surgeries can become a bit less effective. So we try to limit those to the minimum we need, but there's not a number that you would say this is the way when you would stop. If you're doing surgery inside the eye, there's a really rare risk called sympathetic ophthalmia, where your immune system can decide to attack your own eye. But that's really in the order of 1 in 100,000. Like, you're kind of 10 times more likely to be struck by lightning than that happen. A lot of those MIGS devices, you could go in and do other things without it being a problem. When is it too much? I normally find that's a discussion with each individual patient, because it depends what the requirement. I have a lot of patients who live on remote farms, and it's really important to them to be out there on their own property. You have patients where being in your own home is critical, where maybe saving, being driving, or, it's where we set that risk acceptance bar. A general rule I often use is, if someone could see with that eye to be able to navigate around their own home, so if they only had that eye, could they get in and around their own home and stay in their own house, then that vision is worth fighting for, because that's really good independence. And when I say that, I'd also hark back to what I said at the start, which is it's only a very small proportion of people who had that risk of going blind in both eyes with glaucoma. So yeah, it's a balance with each patient, I'd say.
Well, I think that's great to hear. And I think it's great that you're putting the patient situation first in all those situations and involving them in the decision making. I think that's really great. And I'm sure there are a lot of people listening today that would feel the same way. What about the pros and cons of having lens replacement surgery? So essentially a cataract surgery without cataracts, or very early signs of cataracts.
In that case, it's not so much a glaucoma decision. There was some... Doing cataract surgery does bring the pressure in the eye down a little bit. There are arguments within the ophthalmology community as to whether cataract surgery alone is a glaucoma surgery. I generally don't do early lens surgery unless there's a cataract there. The exception to that would be angle closure glaucoma, or the variants of that, where the lens is actually pushing the drainage angle closed. And then sometimes we will go and do a cataract surgery, even though may not be a problematic cataract there. But there's good evidence for that. There was a big study called EAGLE where they compared people who had a laser and people who had cataract surgery, and the cataract surgery group did slightly better there. So that's a bit different. But in terms of glaucoma, no, I wouldn't be rushing to take out the cataract, take out the lens without a sign of cataract there, because there are some risks in that. But that's a discussion for your patient for the surgeon. And sometimes that's a refractive question. Yeah. As in your glasses script kind of thing.
Sure. Well, but maybe should we explore that? So what are the sort of pros and cons of having combined glaucoma and cataract surgery for someone, with very early signs of cataracts, but also, pretty good vision?
So, I mean, the combined surgery, so the most common combined is that minimally invasive glaucoma surgery we were talking about. Those, either the eye stent or the hydrus. This eye track is probably gaining some increased usage in Australia as well. And there's a few other devices that are mostly done in the US, but occasionally are done here. that combination of surgery is reasonable. Those devices can be put as a standalone. So in Australia, there's a lot of work through Glaucoma Australia as well to get access to that for patients in Australia. So you can get those glaucoma components of it without having to have the cataract surgery. So I wouldn't rush to take out the cataract. I wouldn't rush to take out the lens in addition if the vision's good. In my hands, personally, I just wouldn't take out. If the cataract's not causing a problem, I leave that alone. And cataract surgery is a really safe surgery. It's one of the best, most cost-effective things you can do. But if there's not a problem that you're fixing and there's a tiny risk of having a complication of the surgery, I know that I myself as a surgeon and my patient would be really upset if we ran into a complication and there is a problem at the end and there wasn't a real vision problem at the start. And that's my general rule for approaching these things,
No, sounds very sensible. And is age a factor that you take into consideration when offering glaucoma combined with cataract surgery?
Yes and no. You'll often have a discussion with your surgeon about, life expectancy stuff, or the surgeon will be having just a chat about your general other medical conditions and what your family history was like and things. Because in part of that risk profile that we want to think about is what are the risks for your glaucoma getting a lot worse? And also, how long do we need to make sure that you're seeing well for? I mean, if you really wanted to protect your vision until you were 150, there's a lot more glaucoma interventions you would do, but, we just don't need to worry about that. So it's a part consideration there that we'd need to put into the balance. But no, I wouldn't kind of, put an age limit cutoff for combining things. It's about what's the risk to vision of not doing something, and then what are the risks of us intervening. The only other combined cataract surgery thing is if you combine a trabeculectomy, so the more traditional drainage surgery, with a cataract surgery. And we know that can still work well, but the final pressures you end up with are not quite as good as if you do them as two separate procedures. And so the rare cases where I would consider combining those two is sometimes if someone was much older and we thought, well, look, we just need to preserve their vision for a shorter space of time, you might consider combining and avoiding going through two surgeries.
All right, thank you. And should SLT laser always be attempted before jumping to glaucoma surgery, do you think?
Yes and no. So it's really good. As I said, probably at the start there, it's I'd now suggest that as my first go-to if someone gets a diagnosis because of that light study. And the SLT works well at any stage in the disease process, and only for certain people. So you need to have an open angle form of glaucoma to be able to do the SLT. But occasionally, if you've got more advanced disease and we're right near the center of threatening vision, you might not want to wait for SLT to work. And also, if we don't expect, if someone's already on a couple of medications, they're not working, and we're starting to use Diamox tablets, then you don't have the opportunity of time to sit around and wait. And in a way, once the glaucoma damage gets near the central of the vision, the gloves have to come off, and you kind of have to really jump on it and make sure we knock it down, because once we lose that, we can't gain that back. So in those rare cases, no, you jump straight to something more definitive to manage it. But if it's a normal tension glaucoma, if it's only slowly getting worse, or if it's in the far periphery of the vision, then very reasonable to do SLT before you try something else.
Great, thank you. All right, excellent. And in your view, is it better to have peripheral iridotomy laser or cataracts lens extraction surgery to treat narrow angles, or are both needed?
This is it was previously very unknown, and then there was a great study called Eagle where I think I mentioned before, they randomized people to either have the laser or to have the cataract surgery. A little over 500 people, again, very well designed study. Everyone was masked to what was done, and they found out that the cataract surgery was slightly better in terms of slightly better final vision. Patient satisfaction was a little bit better. The pressure at each time point was a little bit better. And critically, the number of people who went on to trabeculectomy or to blindness was a little better in the cataract group. Now, it wasn't an absolute. It was a little better in each of those categories. So it meant that cataract surgery And this was clear lens extraction essentially. So these were people who didn't have visually significant cataracts. It's like you're saying, that they're not otherwise bothered by their cataract. So we're doing the cataract, when it's not necessary for vision. And so if they fit every single criteria in that, I still have the discussion with my patients at that point, because it comes down to a personal risk, because you're starting with good vision. And we know that if you have cataract surgery, about 1 in 100 people will be unhappy with the final visual outcome or need adjustments to glasses and things. And so as a patient, you have to be not happy, but you have to be accepting of, well, this is the risk I'm taking in going down this pathway. Statistically, I'm more likely to get better on this way, but we know it's a roll of the dice, and there's a possibility it could end up worse. So, it depends. For me, it depends on whether they fit those criteria to exactly follow the trial. And then still I'd have the discussion with the patient about what's their risk appetite in a way for, do they really want to make sure this is definitively done in one operation? Are they really worried about surgery? Would a small drop in their vision be devastating for their other life or their work? Are they a taxi driver or a truck driver or something like that?
Yes.
And the timing and those things will help you work out for an individual person, what should we do?
Fantastic. All right. And obviously it sounds like treatment moves fast. There's constantly new techniques and products coming onto the market and so on. So what is still the most common glaucoma surgery, and why is that? Does that have such popularity?
Well, that's actually, it's interesting because it was up until about 5 years ago, it was trabeculectomy was the most common glaucoma surgery. I actually just looked this up in anticipation of this question, but the minimally invasive glaucoma surgeries in the angle at the time of cataract surgery have now overtaken that by a long shot. So the recent data, actually, I pulled this up today. So there was in the last 12 months to July last year, there were 390 minimally invasive angle surgeries without cataract. There were just over 8,000 minimally invasive glaucoma surgeries with cataract, and there were about 1,800 trabeculectomies. So that means there's a lot more, a lot more, 8,000 versus 1,800, a lot more of these combined cataract and glaucoma surgeries going on. Which probably speaks to the safety profile of those surgeries, in that much more people are comfortable doing those a lot earlier.
Yes.
The thing we'd like to see, and we still don't have the best of data on this, is will that result in less trabeculectomies down the track? I suppose that Hydrus stent study that I spoke about was really promising in that regard, because we saw less visual field progression over time. But as long as you have that discussion with your surgeon about what's the extra risk of doing this, and what are we hoping to achieve, then I think that's a very reasonable strategy. You can see why it's become a very popular surgery, or popular, very common surgery.
It's interesting, and I guess on the inverse, what are the sort of least common surgeries and that are offered and that you deliver?
There's been a bit of a shift. I mean, there's a lot of very complex, unusual surgeries in glaucoma, but then glaucoma is also, there's a bunch of very unusual conditions in glaucoma. Aqueous misdirection is one that comes to mind, where one of the longest surgeries we do is something called an iridozonulohyaloidovitrectomy, which is most of the alphabet twice. So those kind of things are very rare, but that's for rare conditions. There is a shift in what people are doing. So it's interesting, trabeculectomy, even when I started training, was what we did for the vast, vast bulk of things. And we did hundreds of trabeculectomies through training. Whereas there's been a big shift to a lot more MIGS devices that avoids a lot of that surgery at the front end. And then there's, even once you get to trabeculectomy, the Zen and the PreserFlow that I talked about in that procedure before, they're still technically trabeculectomies, but with a lower risk profile, and you can avoid the other side of other trabeculectomies. So that's shifting the pattern of what is happening, and when you're deciding to do different procedures.
Great, thank you. And listen, we've sort of hit the 30-minute mark. So although I've got quite a few questions still to come, I think I'll probably just sum it up with one more question. And that is, we've talked about surgery. What are the most common post-glaucoma surgery complications that people could expect?
I had that list up a little earlier. So if you've had a minimally invasive glaucoma surgery, usually it's a transient blur. You'll often get a bit of blood come back into the eye. And so that can blur the vision for up to a week or so. That's generally actually a sign of success in the long run, because, you know, you've got the device it's going into a vein. And so until the pressure equilibrates between the inside of the eye and the blood vessel, you'll get a bit of blood flow back. But yes, that can blur vision for a little bit. A spike in pressure for a short period of time is the most common thing with those minimally invasive glaucoma devices. With trabeculectomies and tube shunts, it depends on if you have early or late complications, and that's the big difference between the two out of that big trab versus tube study. And really a very low pressure can be a problem. So, you know, at one end of the spectrum, if your pressure is too high, your glaucoma is getting worse, and we're trying to bring it lower and lower. But if we get particularly below 5 or 4, you start to get the eye wall won't hold well, and the vision can blur from that. And that can be quite common. And then scarring is the other big thing that we're always in a battle with in glaucoma. You're putting a drain where there's not meant to be a drain, and then you're asking the body not to heal it up, but just heal up just the right amount, please. So, you know, a lot of people will have to have adjustments to their glaucoma surgery if that occurs, to either get rid of some scarring or heal it up a bit more if it's not healing enough.
Fantastic. All right. Well, listen, thank you so much. I know we're almost out of time. I do want to take this opportunity to thank our wonderful sponsor for this live Q&A series, and that is Glaucos. They don't sponsor just this particular episode, but actually are going to sponsor the entire calendar of events, and we're very, very grateful for their support. Listen, I think it's been a fascinating discussion today. I know from conversations that I have with patients that transition to surgical intervention can cause a lot of anxiety. You know, surgery on the eye sounds very serious, and obviously the stakes are very high, you know, particularly when you're talking about people's long-term vision. So I think this has been a really practical discussion. I hope it's going to be valuable to all of the people out there that are watching this now, and also maybe in the months and years ahead. So thank you very much, Dr. Dunn. We really appreciate you making the time today for us all, and look forward to seeing you very shortly.
Thanks very much, Richard. Thanks for the opportunity to talk.
Our pleasure. Thank you, everyone. Happy World Glaucoma Week, as it is this week. And if you're not already participating in our 7 Sites Challenge, please jump online, 7sites.org.au. And if you're not actually taking the challenge yourselves, maybe consider supporting someone who is. So thank you again, and we'll see you very, very soon.